Good afternoon, everyone. Thank you so much for having me. I am very privileged and honored to be speaking to all of you today on this Monday afternoon. I am very, impressed and appreciative of what Gilda's Club is doing for its patients. I just have a family member, herself who's just diagnosed with cancer, and what you guys are doing is really fabulous. So hats off to the Gilda's Club and everyone who is supporting patients in their cancer journey. So let me go ahead and pull up my presentation here. And I don't know if, let me see if I can share the screen. Let's see. Okay, there we go. Can everyone see that?
From unavailable.
Okay, great. So as Beth mentioned, I'm very happy to be back in Michigan and serve Michigan patients. So this talk is going to be about useful things to know about polyneuropathy.
Hello.
And
please leave a message.
I think there's, it's okay. We'll just give it time to.
Of course, it would do it right now.
Right. So, so this talk is really a topic that's near and dear to my heart. When I was down at Ohio State, it was one of the first talks I gave to the family medicine physician group, actually. And when I came up to Michigan, I've given talks to different audiences. It's been a bit busy last month and a half. But this is sort of the bread and butter of what I do. And hopefully in the course of today's talk, as patients or families, with loved ones that have neuropathy, whether it's due to chemotherapy or other causes, you can sort of get a nice, plan of care in terms of what to do and just to know the lay of the land. So let's go ahead and get started. So the goals for today are to go over the basics of polyneuropathy. So you'll hear the term polyneuropathy used, and I think Dr. Ann Little, my colleague who gave the talk in previous years, might have used that term, or peripheral neuropathy, or sometimes you'll hear us just say neuropathy, and that's really all the same. So we'll sort of go over how to diagnose it, how to test for it, common causes of neuropathy, so what I call the big 6 causes, which everyone should be aware of. Look at the role of exercise in reversing neuropathy, which is really an impressive intervention, not just to be healthier to feel good, but to actually reverse neuropathy. And then look at pain control strategies, which is obviously a huge part of quality of life. And then to just sort of, what's really fascinating and really cool is we are currently living through this gene therapy revolution. So no longer is this something that you hear about coming down 5 or 10 years from now. As we speak, people are getting gene therapies injected into them that actually alter their genetics to treat genetic diseases, of which hereditary or genetic neuropathy is one. And so that's really exciting, and I'll just touch very briefly on that. So polyneuropathy, of course, as the name suggests, refers to the fact that you have involvement of many nerves. And pathos is Greek, for pathology or pain, but in essence, it's a disease of the peripheral nervous system, and it's a dysfunction of everything outside of the central nervous system. So nerve roots, nerves, but the idea is that it should be widespread. So if I have carpal tunnel syndrome, which is really common, that's not a polyneuropathy, that's just a carpal tunnel syndrome. Or if I have a pinched nerve root in my neck, that's not a neuropathy, that's just a pinched nerve root. It might look like a neuropathy, but a true neuropathy affects multiple nerves. So what does it look like usually when you have a neuropathy? So as is suggested by this picture, patients will have typically symmetric pain or burning or numbness or tingling in their feet, and it's slow onset. It's more distal, so meaning it starts in the feet and works its way slowly up into the legs. It has usually motor and sensory components. There is usually a lot of pain. It can cause loss of balance. And I get the question a lot in clinic, is it going to make me paralyzed? Am I going to be wheelchair bound? And usually the good part is it's not going to, cripple patients, but it can be debilitating. And so it's just important to keep that in mind. And we'll sort of go over what is not neuropathy, because that's equally important too. So just some points about having polyneuropathy. And this is really important. Just sort of why is it important to diagnose it and know that you have it? Because you can injure your hands and feet without noticing. So, wearing protective gloves when you're working around the yard or at home, or, working with sharp objects or cutting vegetables, being careful because you might accidentally injure yourself or not, feel the cutting tools pretty well. Using well-padded, pot holders when cooking, inspecting your fingers and feet regularly, wearing well-soled shoes when you're outside or inside to avoid any, splinters or any, any injury that might happen without noticing. And then to avoid burning yourself, accidentally. So using cold water, gradually warming, that sort of thing, I think is really important. Other things, and this is, obvious when you think about it, but really underappreciated. So if you can't feel the gas pedal or the brakes, driving's not going to be really safe. So I counsel my patients, make sure you can feel the gas pedal well. Make sure you're safe around, especially in the wintertime, reaction time can be affected. Stairwell landings or areas that are prone to trips and falls, make sure there's well friction surfaces, and avoid any obstacles like, cords or etc. And then I tell all my patients, if you're having falls or near falls, etc., there should be no shame in using a cane or walker or wheelchair if you need it. Because, God forbid you fall, you crack your hip, you injure yourself, it's going to be really bad. And so, yes, it might not be, the most appealing to use a cane or walker, but it really is important to prevent falls when possible. So I'll be talking about typical neuropathies, what we call a stocking glove pattern. But just bear in mind that not all neuropathies are the same. So neuropathies, as we said, is any pathology or any disease of the peripheral nerves. There's a condition called Guillain-Barré syndrome, which I'm sure some of you know or heard about. That's a much more severe neuropathy that can make you go into the hospital, can affect your breathing, can cause facial weakness. So that's not, typical. That's actually atypical and pretty serious. You can have a lot of pain with, foot drop or wrist drop, right? And that is also a different type of neuropathy where you actually have a full, wrist drop, your hand is really weak. That can happen with inflammatory conditions like vasculitis. If you have significant weakness with potentially shortness of breath, speech or swallow problems, you want to think about things like Lou Gehrig's disease or ALS. And then when you have an entire limb, like an arm or a leg that's weak, you want to think of damage to the plexus, which is basically the braid of nerves in the shoulder or in the hip region. So these are other things just to think about when looking at, do I have neuropathy or do I have something potentially different? Now, this is sort of a funny slide, but it's very common. And I tell, my patients, not all neuropathy symptoms or quote unquote neuropathy-like symptoms are due to neuropathy. Very often in my office, I'll get patients that are told they have neuropathy and I tell them why, because they'll say, well, I have numb and tingling feet. And, numbness and tingling can be from pinched nerve roots in your low back. It can be from, and that's actually very common, it could be from many other causes. Patients with multiple sclerosis can get it. People with even allergenic skin reactions can often describe burning or numbness. And then edema can be a problem. So just be aware that other problems can present and sort of look like neuropathy, but not necessarily be the cause of neuropathy, or not necessarily be due to neuropathy. So this is just an overview of peripheral nerve anatomy. So we have obviously the brain and the spinal cord running down the center of our spine, and then we have nerve roots coming off, and then we have individual nerves serving, our hands and feet. And essentially, those nerve endings in the hands and feet, because that's the longest, they're far away from the spinal cord. That's where the nerve endings are. They're most prone to injury. So you could think about it, their cell bodies are way back up here in the spine. So whenever you get neuropathy, let's say due to diabetes or alcohol or chemo, it's going to damage the feet first. And as it works up the feet, it usually gets up to the knees or, just below the knees. Then it starts to affect the hands because it damages the farthest parts first. Now, one point that's important is not all neuropathies are the same size. You can have large fiber neuropathy or the big nerves can be affected, which are shown here. You can also get damage to the small nerves. So why is this important? Because a lot of times patients get an EMG or nerve study because they've had burning feet, and they're told, well, the EMG nerve studies are normal, you don't have neuropathy, but that's actually false because you can have neuropathy damaging the small nerves that wouldn't show up on a nerve study. So that's a point we'll get to in a moment, but just wanted to emphasize that. So let's say, your doctor tells you, well, I think you have neuropathy. You should get checked out. Usually what will happen is you'll get a nerve conduction study. And the nerve study involves this stimulating electrode being applied over different nerves. We basically mark it, like here, for example, it's the median nerve, which is the carpal tunnel nerve. And you record just like you would, with any other waveforms, and you get 2 wave responses when you stimulate at 2 different sites. And using those 2 different wave responses, you can calculate velocity, you can calculate latency, amplitude. It gives a lot of really useful data about how your nerves are conducting. The second part of the test, which for those of you who've had it, is the EMG or the needle exam. We take a small needle and poke different muscles in that limb. And the muscles, the way they fire tells us how the nerves are doing. So if the muscles are firing in a normal pattern, that's good. It's the nerves and muscles are healthy. If you have what's called a neuropathic pattern, the muscles are telling you there's damage to the nerves. And that's because the muscles are kind of like the downstream of the nerves. So whatever happens upstream shows up downstream. And then you can also get damage to the muscles themselves. But just bear in mind, if you were to get an EMG, this would be the second part. That would sort of tell you what pattern of nerve damage you have. So as I said earlier, a normal EMG does not rule out a neuropathy if it is small fiber. So this is really important. You can have big fiber neuropathy, you can have small fiber neuropathy. A big fiber neuropathy can be picked up on this nerve test, but a small fiber neuropathy would not be picked up on this nerve test. And you need to do a separate test for that, which is a skin biopsy. So the skin biopsy is when you actually poke 3 different sites, usually the proximal thigh, the distal thigh, and the distal leg, using a punch biopsy, and you stain it under a microscope. And this is sort of showing here what it looks like. We use this small punch biopsy device. We apply it over 3 different sites. And it's shown here in the top right, for example, in someone who's diabetic, because like we said, it's usually a stocking pattern. The farthest parts are affected first. You'll get tissue damage farther away, but as you get closer to the upper part of the leg, it usually looks better. So you can see here, for example, in panels A and B, 2 samples of skin biopsies looked at under a microscope. Panel A is at the calf site where there's no black dots in this layer here called the epidermis, okay? So there's a lot of nerve damage there, small fiber nerve damage. If you look at panel B, the nerve, you can see sort of these black squiggly lines and dots. That's telling you that the nerves are still intact and working. So it tells you there's damage at the calf site, it's better higher up, and this tells you you have small fiber neuropathy. So what are the big 6 causes of neuropathy? Now that we've sort of talked that you have big nerve damage, you have small nerve damage, the big 6 causes are diabetes and prediabetes, chemotherapy, B12 deficiency, alcohol, plasma cell disorders, and genetic causes. So let's talk about diabetes. So diabetes is by far the most common worldwide cause of neuropathy. About half of all causes in the world are due to diabetes, half of all causes of neuropathy, and half of all diabetics have neuropathy. And they might not even know they have it. It's really common. Of course, there's type 1 and type 2. But what I want to emphasize here is that you should not rely just on a hemoglobin A1C alone to exclude quote-unquote diabetes. So a hemoglobin A1C is helpful, but it's not the most sensitive test. So oftentimes I'd like to get a fasting blood sugar. As I'm sure for those of you that are diabetic or have family that are diabetic, fasting blood sugar of over 126 diagnoses you with diabetes. A fasting blood sugar over 100 diagnoses prediabetes. Now you can also do what's called a 2-hour oral glucose tolerance test. And what happens is patients come in, again, having fasted overnight, they'll check their fasting blood sugar and then give them a sugary drink to consume and check their blood sugar 2 hours later. If it's over 200, that is diabetes. And if it's over 140, that's what's called impaired glucose tolerance, which is kind of like prediabetes. And basically, of those patients that have impaired glucose tolerance, 30% of those go on to develop frank diabetes, 25% go back to normal blood sugars. And why is this important? Because we now know that the choices you make, especially early on in the disease course, affect the likelihood of developing nerve damage. So my division head, my boss, Dr. Eva Feldman and Dr. Brian Callahan, have done a lot of research looking at the role of diet, exercise, and weight control in type 2 diabetics in particular, which is what is sort of underlying the global and national epidemic. It's mainly type 2 diabetes. And they've shown, and others have shown, that exercise, believe it or not, can actually reverse some of that early diabetic nerve damage. So in type 1 diabetes, it's really important to control your blood sugars, and type 2 as well, but especially in type 1. In type 2 diabetes, controlling blood sugars alone is not enough to reverse nerve damage. Exercising, watching your diet, eating healthy fats like avocados, fish, fruits, vegetables, Mediterranean diet over fried, polysaturated fats can actually help. And then weight control, or just moving, walking, even without weight loss, helps reverse some of that diabetic nerve damage. So the key number I tell my patients is 30 minutes a day or 60 minutes 3 times a week. Just walk, don't have to run, don't have to do anything crazy, just moderate aerobic. There is a supplement called alpha lipoic acid, which I use in my diabetic patients. It showed some benefit, but it did not meet its main endpoint, so the FDA did not grant it approval, but it might help reduce pain and also help reduce some diabetic nerve damage. Now, I did want to mention for those patients that take metformin, there is a higher incidence of B12 deficiency or glucophage. And so you always screen for B12 in those sorts of patients as well. And all patients really, but just to be aware, metformin seems to have an association with B12 deficiency. The explanation, I don't know why, but it's been reported. So this is a study that, one of the earlier studies that was done at University of Michigan, looking at 32 patients with impaired glucose tolerance, and they did skin biopsies looking at the intraepidermal nerve fiber density. Sorry about the abbreviation, but this is basically just looking at the fiber density after 1 year of exercise and dietary counseling. And what this figure is showing you is that after 1 year, okay, of exercise, the patients that actually underwent regular, sustained exercise had improvements in their nerve fiber density. Okay, that was significant. And it was mostly at the proximal thigh site. But, this actually did seem to suggest that we could reverse early diabetic damage through exercise. Just to show what this looks at under the microscope, patients, for example, in panel A or B or C or D, shows you the difference between baseline when you have very little nerve fiber endings in this epidermal layer, and panel B, where there's some preserved dermal fibers at baseline with reduction in the epidermis, but in panel C, you're starting to experience some increase in this epidermal reinnervation, or what we call, and in panel D as well, so increase in the sprouting of these nerve fiber endings, where these arrows are pointing, after 12 months of exercise. So this actually led to a national study that we're one side of, which is pretty exciting because people are now looking at the role of drugs, not just to control pain, but actually to potentially reverse disease. And so this is a drug called topiramate, which many of you might know. It's used for seizures and migraines, but it's thought that it might actually help reverse some of this early diabetic nerve damage. And so this is, exercise. So for my diabetic patients, I'll tell them to exercise. I'll tell them to control their diet, to be active, to avoid a sedentary lifestyle. But also I'll sometimes use topiramate or Topamax, even though the study's not done yet, because there's some data that it might help not only control pain, but also potentially reverse some of that early diabetic nerve damage, potentially. So moving on to chemotherapy. So chemotherapy neuropathies are very common and a big problem for people going through, cancer treatment. They can happen right after, shortly after, or chronically after exposure. Certain drugs are strongly associated more than others. Certain drugs are dose dependent, meaning the higher the dose, the more likely you are to get it. Others, it's not related to dose. Most of the deficits are sensory, meaning you'll get tingling, numbness, burning, prickling, electrical, jabbing sensations, or just lack of sensation, much more than you'll get in motor or muscle weakness. And depending on the severity of the neuropathy, the oncologist might choose to switch the chemo or continue with the same chemo and manage symptoms. This is just a table showing some of these common drugs. So cisplatin, or the platinums as they're called, carboplatin, oxaliplatin, used for, breast cancer, for example, or other cancers, can give immediate, some of these can give immediate or long-term effects, one of which is called coasting. So even when you stop the chemotherapy, the effect can continue to build up months after. Vincristine can give you autonomic neuropathies where you get lightheadedness, sometimes dry eyes, dry mouth, so the automatic fight or flight system can be affected. And then the Taxols can also are a big culprit in neuropathy. One class that I wanted to touch on are called immune checkpoint inhibitors, and these are actually newer, and they're sort of more severe typically. These were developed to treat certain cancers like melanomas, lung cancer, pancreatic cancer, And they can give you the typical stocking love neuropathy that we talked about at the very beginning, but they can also give you some of the atypical neuropathies that we alluded to, Guillain-Barré syndrome, CIDP, or chronic inflammatory demyelinating neuropathy, or even other disorders like myasthenia gravis, etc. And the reason this is important is because they can be treated with certain drugs sometimes, like steroids or intravenous immunoglobulin or IVIG. Typically with the other chemotherapies, if I were to go back here for a moment, these ones and others usually with time will get better. So the idea is if there's, unacceptable nerve damage, to reduce the dose or switch it, but the idea is that over time the nerves will heal and get better, but the deficits sometimes do persist. So treatment of painful neuropathy, and I wanted to mention this point here because it's sort of unique to chemotherapy neuropathy, is that this drug, duloxetine or Cymbalta, has the best data, whereas other drugs we commonly use don't have as strong evidence to support their use. In general, and I'll talk here about pain management, not just for chemo, but for all neuropathies. In general, my approach when I see patients in clinic is to go class by class. So what I mean here is, for example, many of us have heard of gabapentin or pregabalin, which is also called Lyrica. In general, if someone has tried gabapentin or pregabalin, and it's dosed TID or 3 times a day, and they don't respond, rather than going to Lyrica or the other drug in that same class right away, I'd rather go to a different class. So tricyclics, for example, amitriptyline or nortriptyline, or SNRIs, duloxetine, which we talked about, called Cymbalta, venlafaxine or Effexor, and titrate upwards. Pain management is really tricky. There's no sort of cookbook approach to patients, but the idea is trial and error. So I tell my patients, if you're having a lot of pain, don't give up. You just have to sort of find the right fit for you. And a lot of times they've not received adequate doses, or they've not been on them for enough of a time. So just to be aware, these drugs take a while to work. As I mentioned, for gabapentin, for example, 8 weeks, nortriptyline, up to 8 weeks, venlafaxine 4 weeks. So I generally tell my patients to be on these drugs for at least 6 weeks before I tell them, it's worked or it's not, because that's important to give it time. Combinations also help. So, gabapentin or Neurontin as it's called, and then nortriptyline or Pamelor, when taken together, have a nice synergistic effect. So that seems to be a good combination as well. So what if a patient fails most drugs? And this is an interesting discussion because I see a lot of patients that have tried maybe 5, 6, 7 drugs and haven't responded to anything. As I said, I go class by class. Okay, the gabinoids, the tricyclics, the SNRIs, but then there's other more unconventional drugs. Mixilotine, for example, is a really good drug, which was initially developed in the 1990s for people with funny heart rhythms, but people found that it worked for nerve pain. So I use that routinely now. Topiramate, as I mentioned, that's being used for a research study, even though it was developed as an anti-epileptic and is used for migraines. And then there's other anti-epileptics, lamotrigine, oxcarbazepine. So, there's a lot of drugs that you can use that don't have necessarily as strong an evidence basis. But I would say, gabinoids, tricyclics, SNRIs, you should probably try Mixilotine or Topamax as a next line, and then sort of try these less common drugs next. I've had patients that have failed everything, and they're in tears, and they're, miserable, and they're depressed. And I think at that point, you should consider spinal cord stimulation. So this was something that, when I was down at Ohio State, was done quite routinely. And it really depends on, the center you're at, and it's usually done by neurosurgeons or pain doctors. And what they do is they'll implant this sort of pacemaker-like device in your back under the skin with these electrical leads that are that terminate in your spinal cord and that basically send these impulses, okay? And these impulses are in a way distracting your brain from sensing the pain in the hands and feet. So it's sort of like when you stub your toe and you rub it real fast, you're distracting your brain from perceiving that original pain. So we do that now routinely at Michigan Medicine. I send a lot of patients for spinal cord stimulation. Not everyone is a candidate, but a good number are. Now there are some patients that have had not typical peripheral neuropathy in the sense of it being stocking glove distribution or both hands or both feet, but they might have had, really bad injury to a limb or to a leg. So I've had some patients who've had, construction site injuries or razor blade or saw injuries or whatnot to their limbs, or possibly, phantom pain after an amputation. The peripheral nerve stimulator is sort of like a spinal cord stimulator, but it's applied just to one limb. And this is FDA approved. So just be aware that, pain medicine is really evolving, and your pain docs should also be able to help direct you, to some of these cooler, newer interventions if need be. So we talked about diabetes, we talked about chemotherapy, we talked about pain management, sort of as an aside, and now back to sort of other common causes of neuropathy. So B12 is a huge common cause. And right off the bat, why is it underdiagnosed? Because internationally, most countries use a cutoff of 400. Here in the US, we use a cutoff of 200, which is more specific, but it's less sensitive. So you're bound to miss a lot of cases of people who are deficient in the 200 to 400 range. So for that reason, we also check another blood test called methylmalonic acid. So a lot of times, patients might have a B12 of 350 or 400 even. You check the methylmalonic acid, it's really high. That tells you that they're B12 deficient. So in the past, most of the time, we used to say this is due to what's called like a tea and toast diet, just no meat, no nutritious sources of B12 in their diet. Alcohol is very common in vegetarians or vegans, but now we're seeing it a lot more in other conditions. So people with bariatric surgery or weight loss surgery, it's very common. People have had parts of their colon resected. Inflammatory bowel disease like celiac or ulcerative colitis, pernicious anemia, where they can't absorb B12. People, like we said, with metformin use, anorexia or bulimia. So it's really quite common. And you should look for it in basically any patient. I would say that it's probably something that, I see a good number of patients that because their B12 was 250, they were told they were fine, but I would call them B12 deficient and treat them. Now the treatment, there's no one standard treatment. But in general, you can treat intramuscularly or IM or PO or by mouth. If people are under 200, I'll do both. So I'll do the injections, and usually I'll do it daily for a week, then weekly for a month, then monthly for a year. But I'll also start them on daily oral 2000 B12. If they're in the 200 to 400 range and it's sort of on the borderline, I'll just do the oral. Again, this is what I do. It's sort of varies from provider to provider, but I found that to be pretty helpful in my practice. You also want to be aware that if they're deficient for B12, there's a high chance they're deficient for another really important vitamin, B1 or thiamine. And this is something that's also really underdiagnosed and can give you pretty bad neuropathies we'll talk about in a moment. Folic acid or folate is another common one. But, it's a little bit harder to tell if folic deficiency in and of itself gives, neuropathy. It probably does, but it's much, much less common. The big ones are really B12 and B1. So moving on, B12 is important and it's serious because it gives you damage to the peripheral nerve. It gives you polyneuropathy, but it can also give you a myeloneuropathy, which myelo refers to the spinal cord. So you can actually get damage to your spinal cord and the peripheral nerve. So severe under or untreated B12 deficiency, people have, you do their MRI of the brain and spinal cord, they can have, white matter brain damage or spinal cord damage. They have difficulty with confusion, memory, depression, vision problems. They can have bladder and bowel dysfunction because it's actually damaging those central spinal cord tracts and leading to significant impairments. So sometimes you'll get imaging of the brain and spinal cord in that case. Okay, so moving on to alcohol. So alcohol abuse or alcohol, dependence is obviously a problem in and of itself. And, I think thankfully, there's so many good resources now in terms of patient recovery and abstinence and medication treatment. But alcohol is interesting because we don't really know how much is enough to give you neuropathy. So I tell a lot of my patients, you don't have to be, dependent or abusing, but if you're consuming a generous amount, right, of alcohol daily with dinner, let's say, and some people do, it's a daily, routine, over years, you'll probably get some neuropathy. So the CAGE questionnaire, as some of you may know, it's a questionnaire looking at dependency or abuse. So C for cutting down. Have you ever tried to cut down? A, are you annoyed when people ask? G, do you feel guilty? And E, do you take an eye opener? I would say probably 9 out of 10 times the patients that I've seen that probably had some alcohol neuropathy would answer negative to this. But, if patients have a few drinks daily over decades, they probably will have some neuropathy because it's a total lifetime exposure that matters. So there are subtle clues that can suggest alcohol neuropathy. There can be magnesium or phosphorus deficiency, low B12. But the big vitamin deficiency that happens is thiamine or B1. And the blood test, the problem is it's not the most accurate. So if I suspect that someone has this, I'll start treatment. And it's usually 100 milligrams by mouth once a day. Now, thiamine deficiency, like B12, can also affect other nerves or organs in your body. For some reason, it gives you hoarseness of voice because it damages this nerve called the recurrent laryngeal nerve. So people get a hoarse voice over time. This is B1 deficiency is also common in people who've had bariatric or weight loss surgery who are not alcoholic. But as a deficiency syndrome, you can, severe cases sometimes can give congestive heart failure and sometimes can look like Guillain-Barré syndrome, can be pretty rapid. So, this is not benign stuff. Most of the time it is, but it's not always benign. Moving on to the next sort of big category of diseases was what's called plasma cell disorders. So just to sort of put it in perspective, because it's not the most obvious condition, think of multiple myeloma, think of amyloidosis, think of those disorders of your blood cells, the B cells in particular, that produce a lot of antibodies or have abnormal levels of proteins. So this is where we do a blood test called an immunofixation electrophoresis, and you look for what's called an M spike or a protein, and you try to correlate that protein with the presentation. And we often work with our hematology colleagues to figure out what's going on. So this is a bit of a busy slide. I don't want you to worry about this, but just as a neurologist or a neuropathy specialist, I work by looking at the protein type. So for example, IgM, IgA, IgG, the neuropathy presentation, if it's sensory or length-dependent axonal or demyelinating, which means it's very slow or there's lots of damage to the wiring, and then the blood work to sort of figure out what underlying disorder it is. So that's paraproteinemias or plasma cell disorders. These are also important. We always screen for them in neuropathy patients. The next big one is hereditary or genetic neuropathy. So I always ask my patients, when they take off their shoes and I look at their feet, sometimes without them even noticing, I'll see this really high arch and these really prominent hammer toes. And I'll tell them, hey, do you notice that your feet look funny or look different? And I'll say, yeah, I've noticed that, and I was kind of going to ask you about that or tell you about that, but they usually, weren't really thinking that that was important. And then I'll ask them next, do you have family that have similarly looking feet, or walked funny, or had difficulty with, balance? Do you have family that, have neuropathy? Did you walk slow growing up? Did you have delayed milestones? Did you, were you ever picked on in school? Did you have a hard time finding properly fitting shoes? And, if there's a lot of suggestion there, I'll go ahead and do genetic testing, because we now know that genetics are a huge cause of neuropathy, estimated to be, the incidence or prevalence of genetic neuropathy is about 1 in 2,500 in the general population. Okay, so as I wrap up, I just wanted to highlight that the future is really exciting. We have a lot of exciting things happening. So gene therapy is now becoming a reality. So this is just a schematic showing a cross-section of the spinal cord, the nerves coming out, going to the muscle. And Lou Gehrig's kind of damages the spinal cord area. There's a lot of research going on there. Genetic neuropathies or nerve damages can damage the wiring on the inside of these nerves or the insulation around it. And then you have the genetic disorders that affect muscles. So think of, Jerry's kids or muscular dystrophy diseases, that damage the muscles down at the end. So this whole pathway from spinal cord through nerve through muscle is undergoing a genetics therapy revolution, as is much of medicine. So I wanted to give an example of a very practical condition called amyloidosis. It's a genetic disorder that can affect your nerves. And what happens is the liver produces a mutated form of this. And again, this might be a bit of a busy slide, but it basically deposits in your end organs, deposits in the heart, kidneys, the stomach, the spine. And it's very prevalent in some populations, Portuguese, Brazilian, Swedish, and Japanese. And there's different mutations. So internationally, this is one particularly common mutation. In African Americans, there's a particularly common mutation, and it can present earlier and later in life. There are now 2 FDA-approved therapies that can actually be infused and reverse, not only halt, but reverse the neuropathy that happens due to this genetic mutation. So this is really quite amazing. I think it's nothing short of a miracle that now we can infuse a drug and alter your genetic disorder so that it no longer causes nerve damage. And this is just showing how they work. So they silence the genes that cause disease. So if you remember from, biology, or we have our DNA, we have our messenger RNA, which is sort of the copy, and then from that RNA we produce proteins. So these drugs prevent that messenger RNA, or that copy that tries to carry the message from the DNA down in the nucleus. It prevents it from causing that abnormal protein to actually be expressed. The other really cool treatment option that's now being provided and researched is actually using viruses to deliver missing genes. So it sort of seems like a little bit of, science fiction, or, but it's actually happening. And viruses, who would have thought, right? We think viruses are these bad, terrible things, that don't have a purpose. It's kind of amazing. You're like, wow, I never thought that we could actually use viruses. The actual shell, they fill it with the missing genes, okay? And essentially deliver that virus into the cell, and that missing gene gets integrated or expressed in the patient and produces the protein that's missing. So for example, this is something that's currently being researched. It's not been, approved yet, but you have these unhealthy neurons in people with CMT or Charcot-Marie-Tooth disease, which is a genetic disease, that are missing certain proteins. So over time, what happens, the nerves just sort of shrivel away. what you can now potentially do if this, gene therapy works in this specific condition is deliver the missing gene, okay? This gene gets, delivered by the virus into the cells. The cells can now produce the protein that's missing, and the neurons become healthy. So this has actually been approved for a condition called spinal muscular atrophy, and kids that were once unable to walk or breathe or live are now walking and developing normally, which is really incredible. So, thank God these, treatments are now available, and I think a lot will be coming down the pipeline for genetic neuropathies and other conditions. So, just again to summarize, to leave time for questions, neuropathies are common and are due to common things. So just think about the common things. Diabetes, prediabetes is equally important. Alcohol, chemotherapy, plasma cell disorders, genetics, and the vitamin deficiencies, as we mentioned, B12 and B1. Keep a lookout for uncommon things when you have a pattern that's different from the stocking love pattern. So if you're getting weak really rapidly, or one limb is really weak more than the other, you probably want to get checked out, make sure it's nothing else. Pain control is largely trial and error. So I tell my patients, don't give up. You have to kind of keep trialing through, but just make sure you try them properly. Exercise is the only disease-modifying therapy that's available for diabetic neuropathy, but probably also helps for patients with chemotherapy-related neuropathy. And we are in the midst of a gene therapy revolution where once untreatable conditions can now potentially be treated, but cost will be the biggest challenge, as it always is, unfortunately. But that's a separate discussion. But it was a pleasure talking to you. I'd like to open it up for sort of a town hall style, question and answer, as many questions as you have. So please go ahead.
Thank you so much, Dr. Stino. Such
My pleasure.
amazing and important information.